Next speaker is Dr. Sidharth Sethi, and one of my good friends from India. And he has done a lot of work when it comes to the critical care nephrology, and he's going to talk about advances in AKI.
Thank you. Thank you for the introduction, Dr. Arula. So first of all, I would like to thank the organizing team to invite me here. So over the next few minutes, I'll be talking about the newer advances in pediatric AKI in the last 1 decade. So before we talk about AKI, we need to understand that we need to identify AKI early before this child really goes into severe AKI and the need for dialysis. So let's talk about how can we identify. So all of us need to understand that yes, as pediatric nephrologists, we know that children who are ventilated, who are on inotropes, they are at a higher risk of AKI. This is a study from Texas Children's. Another study from Montreal Children's where they looked at all the pediatric ICUs stay over 12 hours and they found that almost 18% had AKI. And another study from LA where they looked at all the pediatric ICU patients and 10%. So the incidence varies depending on how sick your patient is. Now, looking at pediatric AKI post cardiac surgery, and it's one of our research area, and we all are aware if a child undergoes a cardiac surgery, there's a higher risk of AKI. A study from Montreal looking at almost 390 patients. But we are also aware that if a child undergoes a complex cardiac surgery, and here is a neonate who undergoes a complex cardiac surgery, the risk of AKI was much, much higher, almost 60%. Now, in my institute at Medanta, we have done multiple studies on AKI, and this was one of our first study where we looked at AKI, looking at all the children who undergo a cardiopulmonary bypass over 1 year, and we found that the risk of AKI was around 10%, and 4 children needed dialysis, and all of those 4 children, in fact, died. So, we are aware that AKI is common, but what about AKI in children who undergo a complex cardiac surgery? So, at our center, the infants undergoing arterial switch, a complex cardiac surgery in a neonate, there were almost 150 children over the last 10 years, and again, the risk of AKI was more than 50%. And it's not just about the risk of AKI, it's also about mortality. So when we looked at the odds ratio for mortality, we found that children who were having AKI and other comorbidities like prolonged cardiac surgery, need for inotropes, septicemia, cardiac dysfunction post cardiac surgery had a risk of AKI. Now, AKI is not just about critically sick children, it's also about non critically sick children. This is a study from Texas Children's where they looked at children who received aminoglycosides for more than 5 days, and they found that the risk of AKI was whatever classification you use, whether you go for a pediatric rifle criteria or the Akin staging, the risk of AKI is almost from 20 to 30%, even in your wards. And children who in fact receive a longer treatment, aminoglycosides in the previous month, are at a higher risk of AKI, even in your wards. Now, this is another study looking at from Dr. Goldstein's group, a retrospective analysis, and they found that more are the number of nephrotoxins which you give in your wards, whether it's a neonate or an infant or a child, higher is the number of nephrotoxin exposure, higher is the risk of AKI in these patients. Now, what about neonates? And this was one of the largest retrospective analysis, multi-center international study looking at neonatal AKI. So it was a retrospective analysis, and it was done over 4 countries, and our center was part of it in 2014. So we looked at a very simple inclusion criteria. Every neonate who comes to your ICU who needs IV fluids for at least 24 hours. We're not talking about a neonate who receives phototherapy or is just admitted for monitoring. So here is a neonate who receives IV fluids for at least 24 hours, and the risk of neonatal AKI was 27% in this Lancet publication. And of course, if you have a preterm, there's a much higher risk of AKI in extreme preemies. So we talked about that AKI is quite common in neonates, in sick children in the ICUs, in neonates. Now, how do we diagnose AKI early? And I would just only concentrate on one biomarker because it has been validated in multiple studies on NGAL, and it all started from this Lancet publication where they looked at 71 children who underwent a cardiac surgery, and they looked at the urine and the blood NGAL, and they defined AKI as 50% increase in the serum creatinine over 1 to 3 days after cardiac surgery. Now, there have been meta-analysis, multiple meta-analysis on NGAL, and we all are aware that NGAL is one of the best biomarker, and the diagnostic accuracy for early AKI is quite high. And the diagnostic cutoff to rule out a structural AKI is less than 50 nanograms per ml, and mostly we take a cutoff of 150 nanograms per ml for a structural AKI. So if it's more than 150, it means it predicts a structural AKI in your patient. And NGAL has received US FDA approval, and NGAL is now used in the US FDA less than 21 years. So recently it has been approved in all the ICUs, in pediatric ICUs in the US. The good thing is that it can be incorporated into any standardized lab platform. It's easy, it can be done simple, but of course it's a costly test, which we don't do in every child. Now, what about risk stratification? Once a child comes to your triage, can we think about something, making a score like they do in adult nephrology when an adult is undergoing a cardiopulmonary bypass, receiving a cardiac contrast, they have a score. Now, the first score, and mind you, this score was for children more than 3 months, was called the RAI by the Goldstein's group, where they looked at the risk of AKI multiplied by signs of injury. So here's a child who has a PICO admission or a stem cell transplant or on a ventilator and inotropes. So you give a score and multiply it with the risk of injury defined as percentage of fluid overload or reduction in the estimated creatinine clearance, and you make a score. Now, this was the first study which they published in KI, where they looked at multicentric analysis of 4 centers, and they found that if you look at the renal angina index more than 8, whether you define it by the estimated creatinine clearance reduction or the percentage of fluid overload or the worst of any of these two, you can see that the area under the curve to define AKI was much more than the usual PRISM and the PIM scores which we use in the ICU. So it was a good score. Now, what if we can add a biomarker here? So this was a prospective study done by Shaina and group, where they looked at pediatric ICU patients, and they looked at whether if you just add one biomarker, I know it's costly, but what if you do add one biomarker to your RAI? And they found that the negative predictive value was quite high, almost 99%. So if you have a patient whose RAI score is less, biomarker is normal, he's not likely to have AKI, and you can, do usual care in this patient. And you can again look at the area under the curve. By just adding NGAL, it increases the area under the curve to diagnose AKI more. So our group with Rupesh, he is still here. We'll miss you, Rupesh. So we looked at the AKI, all the studies looking at the RAI, and these were almost 149 studies. 10 studies, and we again looked at the sensitivity, specificity to diagnose AKI. And mind you, whenever we look at the scoring systems, we look at the negative predictive value. So if your score is negative, your patient can go to the usual just care. You don't need more advanced nephrology care. So again, the negative predictive value is 94%. And it's not just about AKI, it's also about mortality. If your patient has a risk stratification score which is higher, he's also more likely to die. So the pooled odds ratio was 4.5 here. Now, we have been looking at multiple risk stratification score. This is one of my postgraduate, and a part of her study was risk stratification in cardiac surgery. So she looked at over 1 year period children who underwent cardiac surgery and trying to look at whether we can find a clinical scoring and a lab scoring for children who may go into AKI post cardiac surgery. So she made a clinical predictive model looking at age, gender, the complexity of the cardiac surgery, creatinine type of the surgery, and we could find that if to your clinical model, if you can even add a pre-operative albumin creatinine ratio. See, in adults it's known, if you have an adult who has proteinuria, he undergoes a cardiac surgery, he's more likely to get AKI. But there are not many pediatric studies on this. So this study again showed that in children less than 2 years and more than 2 years, again the area under the curve to diagnose AKI, to predict AKI, was higher in children who had pre-operative AKI, proteinuria. So we've been looking at neonatal AKI since last 10 years. So thanks to a grant by the ISN, what we have done is we have collaborated with multiple mother and child hospitals called Cloud9 hospitals in our country, and part of multiple hospitals of mother and child here. So we call ourselves Thinker. It's called the Indian PCRT Iconic Neonatal Kidney Educational Study. And one of our first study was looking at whether we can, what's the incidence of PD? If a newborn, all of you look after neonates, what is the incidence of PD in these neonates? And we looked at the same inclusion criteria, IV fluids for 24 to 48 hours, 1600 prospective neonates. And we found that out of 1600 neonates who are in your ICU, who receive IV fluids, the 9% babies need PD. This was, in fact, this is the first study looking at the real world incidence of PD and severe AKI neonate. And we also found if you have one increase in serum creatinine, 12 hours, there's a higher need for PD. If you have a higher Apgar score, less need for PD. And there's also a relation of anemia and the need for AKI in these patients later on. So in fact, in PD International, in this study, Dr. Shroff also wrote an editorial on our paper called Tinkering with the Neonatal AKI. We want to also write something related to tinkering in coming months. And Dr. Shroff also mentioned that, of course, in neonates, when we talk about, we need to also think about more what specific modalities for KRT can be done in neonates. There's much to work on in specific areas in neonatal AKI. So based on our group and our data, we have tried to divide and make a score for risk stratification for neonates. I said RAI was for more than 3 months, and now we have devised a score called Neonatal Stars. So it's after the collaborators, which includes neonatologists, pediatric nephrologists, statistician. So it's a simple score. It includes all the clinical criteria, and there's only one lab criteria, serum creatinine, within the first 24 hours. And we have found that if your score is more than 31.5, this neonate is about to get AKI in the next 7 days of the ICU stay. And again, we look at the negative predictive value. So if this score is fine, your baby can go back to the mother. So this score the first publication was on devising the score, and then we validated the score on another 700 babies, and we could again find similar results looking at a cutoff score of 31.5. Now, once when we were replying to the reviewers taught us a lot in the last 1 decade. Once a reviewer told us, so what if you can predict AKI stage 1? Tell us whether your score can predict peritoneal dialysis. So this made us think about whether we can predict PD in these neonates. And this is what we publish in KI reports, looking at our data on 1,000 neonates, prospective data. And we found that if your score is more than 66, then there is a very high chance that this baby may need PD in the next few days of the pediatric ICU stay. 31.5 is the cutoff for AKI, and now this score has been incorporated with the National Neonatology Forum of India. So very soon our country's National Neonatology Forum of India is coming up with a neonatal AKI guideline where they have incorporated the same scores, and we are talking about this research in multiple neonatal ICUs in the country, which has been happening. So yes, we were told to make an online dashboard. So if you just go on pcrt.com, there are multiple educational material there, and there's also a dashboard where you can just go down and you can check the score of your neonate easily. So this is just like machine learning, looking at a lot of data and trying to find the risk factors and predicting AKI. So when we look at AI and machine learning in these patients, all of us have done a significant progress in terms of finding a model and selecting a model, and some average progress in terms of validating this. But of course, we need there is minimal progress in terms of QI and more multicentric trials, which we need to work on. So this is the kind of model which NNF India, the National Neonatology Forum India, and with the PCRT group is coming up. So here's a neonate who comes to your triage. If his risk stratification score is high, these are the children in whom you may consider one biomarker. We're not talking about costly biomarkers in each patient. And these are the patients who need more attention by a pediatric nephrologist. And if your risk stratification score is negative, you have a good negative predictive value, and you can just go for a usual care in these neonates. Now, for the residents here, I talked about this in the workshop yesterday, that you need to look at fluid overload in all of your patients. Every day in the ICU, cumulative fluid overload also in all the admitted patients. Because we are aware that fluid overload is independent predicted, it can predict mortality in these patients. So this is data from PCRT group. This is data from my institute, where we looked at fluid overload in children who are not on dialysis. So we all know AKI happens in the first 7 days of the pediatric ICU stay. We all know mortality is highest in the first 7 days of the ICU stay. And now we are saying that patients who have a high fluid overload percentage are also in the first 5 to 7 days of the ICU stay. And these are not on dialysis, these are patients like ARDS, and it predicts their oxygenation. So if you look at a higher peak oxygenation index with fluid overload, they have very good correlation. And the correlation index also increases as the fluid overload increases. So the strength of correlation also increases in these patients. So we talked about risk stratification, we talked about incidence. What are the challenges we all face when we see a child who has a pediatric AKI and he needs dialysis? So this is one of the review which we published. Dr. Yap is here, Rupesh is here, where we talked about advances in KRT in infants. So when we did a survey all across the world, what is the most common modality for children who need any kind of KRT, and we found PD is quite common in less resourced nations, while CRT is common in well-resourced nations. So, but not everyone has access to CRT. So the first publication from Taiwan way back in 2012 talked about doing a modified hemodialysis called sustained low efficiency dialysis with convection in children, but this study was not done in smaller children, and most of these patients were not on inotropes. So they had around 70 patients who were on inotropes, and they did a sustained low efficiency dialysis. So over the last 10 years in our country, we've been looking at sustained low efficiency dialysis in patients, and this was our first publication where we looked at retrospective analysis from Delhi, from Kolkata, from Pune, and we found that patients were sick when we were doing a modified hemodialysis in these patients, doing a slow solute removal over 6 to 8 hours. Most of these patients were sick, they were having MODS, they had septicemia, they were sick patients. And I discussed in the workshop yesterday what blood flow rates we use and keeping a lower dialysate flow rate in these children. And this was a heparin-free dialysis in these patients. SLED improved their blood pressure, they were well tolerated, it improved their metabolic acidosis, and only 13% of these patients had premature session termination. So since last many years, we've been doing SLED with convection. So not everyone needs CRRT. So we use SLED with convection in the ICUs, and I told you in the workshop yesterday that we do need ultra pure water. If you have availability of the ultra pure water, you can use SLED with convection using the newer models of the Fresenius machine. So this is using heparin free SLED with convection, and again very good outcomes, only 10% session terminations, and it was well tolerated. So way back in 2020, 5 years back in Melbourne, all the LMICs, Dr. Asiri was there, and all the, Dr. Yap was there, Rupesh was there. We tried to make a consensus for SLED or extended daily dialysis in children. So this is, I would refer you to this publication of Hemodialysis International. Now, coming to the challenges, now, one blessing which we have is, of course, smaller filters. All of us have now access to HF20 in CRRT, which has a very small surface area. And if you look at the membrane, the PAES membrane, which is very well tolerated in neonates, this all came into use after these 3 major publications, though the numbers were just 4, 12, and we've been using HF20 in smaller infants. And of course, it is a blessing when we use CRRT in smaller patients. Now, last month, our group also published looking at citrate anticoagulation for children. Now, in our part of the world, we have dilute citrate availability. We don't have the concentrated citrate. And with our group, we have devised a protocol for citrate using a dilute one and keeping the post-filter ionized calcium of less than 0.5. And we have been seeing, normally when we start with a conventional citrate, the ionized calcium in the circuit is almost like zero. You don't need to give so much citrate to your patients. So less than 0.5 is acceptable, and systemic ionized calcium of 0.9 or more is acceptable. Now, there are some new exciting machines coming up in the market in the next few years. We are excited about NIDUS, which is already in use in UK, called the Newcastle Infant Dialysis and Ultrafiltration System, which is just like an exchange transfusion. It's like a syringe-based pump with an extracorporeal volume of just 9 to 17 ml. And it's just like an exchange transfusion. And there are a lot of studies on NIDUS from the UK. It's a syringe-controlled single lumen device. Now, Dr. Malcolm has also published that it has a very good sensitivity. So if you compare it with CRRT, HF20, if you compare it with Fresenius, it has a very good sensitivity and much less error as compared to the conventional machines. Now, we are all excited about Carpe Diem, and I'm sure it is coming to this part of the world also with Medtronics. And we are all fascinated by how Dr. Ronco devised this. And it was based on these two studies from Dr. Ronco that it brought to smaller infants. Aquadex is like a slow continuous ultrafiltration device, which is even used in adults with heart failure. And David Ashkenazi and group have tried to use it for children as a part of CRRT device also. But for us, I would say it's more of a slow continuous ultrafiltration device. So you should take it like this. It is available here also, I'm sure, and as well as in India as well. So if you compare all of these devices, of course, as we go to Carpe Diem and NIDUS, we are more specific. We can manage these patients with less error. And I would not go into the details, but I would like all of you to refer to some new publications on that. Now there are publications on how to manage metabolic disorders with hyperammonemia, where PD is recommended if you don't have any other modality, but CKRT, especially the high dose CRRT, is recommended in hyperammonemia in inborn errors. And this is part of the PCRRT Iconic initiative with Dr. Bunchman, Rupesh, Dr. Yap, and Mignon. So, and I would also refer you to updated information on liver failure. That now we have guidelines on how to manage a child with liver failure. And there are now well-defined guidelines. And this is what we every day follow, talking about worsening hepatic encephalopathy. So it's not just one indication, it's multitude of indications. You have a child with AKI, worsening hepatic encephalopathy, ammonia is worsening, you're not able to manage it. Remember, CKRT is the modality of choice in liver failure, and we do it every day of our lives. When a child is planned for a liver transplant, we do go for CRRT in these patients and slowly switch to other modalities, or they go for a liver transplant. So remember, CRT is now as a bridge of transplant in liver failure also. So to summarize, over the last 10 years, there have been landmark studies from looking at risk stratification in terms of RAI for more than 3 months, STAR score in neonates. There have been multiple new guidelines, and thanks to the PCRRT group and vision by Dr. Rupesh, Bunchman, Dr. Mignon, and Dr. Yap, that we've been able to work in this direction in the last year. And now we have well-defined guidelines. I would refer you all to a lot of information on guidelines on intoxications, guidelines on intradiabetic hypotension, hyperammonemia. Do look for these guidelines. And I would refer you to this book, which we published in 2018. This is a book which talks about all the information which I discussed just now, from PD to SLED to how to manage a child on CRRT, liver failure, and so on. So this could be a good reference, and you can see Rupesh, Dr. Bunchman, Dr. Mignon here. And I would again thank the scientific committee for inviting me here. It's a pleasure to come to Sri Lanka. I love many cities of Sri Lanka. I love the way Kandy looks, and I always look forward to coming to here. Thank you. Thank you.